Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at IHEA. Welcome, and thank you for registering for today's webinar, Defining a Core Data Set to Support Economic Evaluations of Precision Oncology, a stakeholders-driven approach. Today's webinar will run for a duration of 60 minutes and will be recorded and uploaded on the IHEA website. Before we begin the webinar today, I just wanted to run through a couple housekeeping items. If you experience any technical difficulties during today's webinar, please type them into your chat box at the bottom of your screen, and I'll happily assist. Everyone on the line has been muted except for our speakers today in an effort to eliminate background noise. We'll be holding all questions until the end of the session when we'll open for a facilitated Q&A. From here, I'm going to hand things over to Dee Dee. Dee Dee, over to you.
All right, wonderful. Hello, everyone, and thank you so much for joining us today for the very first Economics webinar. So for those of you who don't know me, I'm Deirdre Wyman. I'm a senior health economist at BC Cancer in Vancouver, Canada, and I co-lead the Economics SIG alongside Dr. James Buchanan at the University of Oxford and Dr. Ilias Goranaitis at the University of Melbourne. The Economics SIG really is meant to bring together us researchers from around the world who are really interested in the economics of genomics and of precision medicine. Our webinar series enables SIG members to disseminate their research, as well as presents an opportunity for us to learn about some of the latest research in this area. The SIG is also in the process of organizing additional events like an annual online symposium to be scheduled in June. So do keep an eye out for future emails from us, as well as keep an eye on our Twitter account where we like to publicize details about our upcoming events. Today, Dr. Samantha Pollard will be kicking off our webinar series by presenting on her work developing a core data set to help support economic evaluations of genomic technologies in oncology. Dr. Pollard is also joining us from Vancouver, Canada. She's a senior methodologist at BC Cancer and specializes in mixed methods research. She's also a fellow SIG convener and co-leads some of our efforts in research and international collaborations. Dr. Pollard holds a BA in philosophy from the University of British Columbia, MSc in Health Research Methodology from McMaster University, and a PhD from UBC's School of Population and Public Health. So with that, welcome, Dr. Pollard, and I'll pass it over to you to start the webinar.
Thanks very much, Dee Dee, and thank you for inviting me to give this talk today. As Dee Dee said, my name is Samantha Pollard, and I am going to talk today about, well, I'm going to talk about a few things. First, I'd like to start off by talking about how we went about developing this core data set to support precision oncology, and then I'll move forward and talk a little bit more about sort of what we have done, what we've been working on since establishing this core data set in terms of being able to implement it at BC Cancer as part of one of our ongoing initiatives. So I'm looking forward to generating some discussion, not only around the development phase, but also, what we did next. How did we actually put this data set into motion? Before I get going, I'd like to acknowledge my co-authors on this work. A number of you are on the line today. I'd like to, thank you for, being here again. What I want to talk about today, I'm going to cover a lot of what's in the paper, but in terms of, our specific methods and the very exhaustive data set itself, I would certainly encourage you to have a look at the paper where we go into far more detail about, what we did and what these data elements look like. But really for today, I want to just give kind of a bird's eye view of how we approach this, give a little bit of background about why we initiated this investigation. And then, as I said a couple of minutes ago, sort of what we've been working on since establishing this core data set and how we intend to move this work forward. So before I go any further than that, of course, I'd like to acknowledge our funders, as well as my own conflicts of interest there. So before I go into the core data set itself, I wanted to start by giving a little bit of background about sort of where this initiative came from, why we moved this work forward. And so I want to define a few terms. I know everybody's coming into this webinar, this session with kind of different backgrounds. So I just wanted to define some of the key terms that I'm going to be talking about today and really kind of provide a little bit of background in terms of why we push this work ahead. So this webinar, this work is really about this idea of precision oncology and how to evaluate precision oncology and how to enable decision-making based on these really rapidly moving innovations. And so precision oncology is the application of genetic testing, genomic sequencing to inform prevention strategies and treatment strategies as well. So we see a lot of support for precision oncology within, from members of the public, from governments, through academia, but there's a number of challenges that we're facing, and that's really what we wanted to address through this work. So I want to step back a little bit and just talk about precision oncology. And so we talk about, identifying a treatment or identifying a sequencing strategy with a view to improve patient quality of life, patient survival. But there's a lot that happens to patients in between getting that sequencing technology and any sort of survival or quality of life outcome. We think through, what are the outcomes that result from that test? What are the actionable findings? And what happens after that finding is detected? And that's a function of things like patient preferences. It's a function of treatment availability and treatment accessibility, as well as what happens if and when an individual initiates that treatment. So there's a lot going on there. And so to be able to really capture that trajectory and be able to say anything about a causal association between something like a sequencing technique and a patient outcome, we really need to account for all of those different stages. And there's a lot of uncertainty. And so thinking about cancers, again, kind of stepping back for a second, when we think of cancer, even within a particular tumor type like breast cancer or lung cancer, we have this increasing understanding that cancers are not necessarily all that similar, even within a particular tumor type. And so one individual with a specific type of breast cancer may respond very, very differently to a targeted treatment or a treatment compared to someone else with a very similar cancer. And often that's owing to, the specific genomic aberrations within tumors. And so when we think about cancer from that perspective, it's not cancer as one single disease or breast cancer as one single disease. It's really a series of very, very rare diseases. And so when we think about it from that perspective, you begin to acknowledge that evaluating causal relationships, evaluating why one or identifying why one person might respond and another didn't is really challenging, because we get into this idea where we've got really, really small numbers of patients with similar characteristics. So building up that evidence base is really challenging. And so I'm sure many of us are aware of traditional study design. So thinking about, a traditional randomized controlled trial where we have similar patients who are randomized to an intervention versus standard of care or some other comparator group. And that allows us to generate causal effect estimates to compare the impact of an intervention. Within precision oncology, those kinds of studies are really, really challenging to conduct. And that's largely a function of the fact that when we're talking about these very rare tumor aberrations, to identify and accrue enough patients to make those associations, to be able to conduct those studies is really, really challenging. And so for that reason, investigators are now turning to real world study designs or observational study designs, collecting real world data to evaluate these types of interventions. Because things like randomized controlled trials, traditional trials, are considered infeasible and kind of impractical, really. And so real world data is a term that is used very frequently, real world evidence. And so just to kind of step back for a second, really define what I mean when I talk about real world data, it's data that's collected outside the confines of a randomized controlled trial. So things like administrative data, electronic health records, wearables, all those kinds of data points are considered real world data. And so they of course can be combined with trial data. But when we talk about real world data and real world evidence, it's what's collected outside of randomized controlled trials. And oftentimes it can allow for estimates of what is the real world impact once a technology or an innovation is implemented. So in the absence of RCT data, we are beginning to see more collection of real world data. And that's really what we want to focus on for the purposes of this work and for this talk today is, how do we collect data from multiple sources, combine them so that we can begin to build out this evidence that I talked about earlier as being relatively sparse and really difficult to estimate, long-term patient impacts, and of course, impacts on the healthcare system as well. So that is all to say that, this current evidence base informing precision oncology and the impacts of precision oncology, both clinically as well as economic outcomes, is relatively sparse, and that's owing to an absence of evidence. And so how do we generate evidence is through good data and through data collection. And so that's really what we wanted to address here is how can we build out data infrastructure? How can we ensure the collection of data that can support the generation of evidence to, again, inform downstream decisions about what is appropriate to allow access to, what is going to provide value for money, what is going to benefit patients as well as populations and health systems. So I just want to provide a really brief example of sort of how evidentiary uncertainty filters down into challenges with decision making. So this is just one quick example of a therapeutic that was developed for NTRK fusion. So it's what we call a tumor agnostic treatment. So it's not just for breast cancer or pancreatic cancer. It's for individuals with advanced cancers who harbor a particular aberration. It's called the NTRK aberration or NTRK fusion. And so so within Canada, again, just a little bit of background. In Canada, we have the Canadian Agency for Drugs and Technologies in Health, and they provide non-binding recommendations to provinces and territories about reimbursement, recommendations to reimburse particular therapeutics. And as part of CADF, you also have the Pan-Canadian Oncology Drug Review, which specifically makes recommendations pertaining to oncology drugs. And so this was a recommendation that was released a few years ago pertaining to this particular therapeutic. And so this recommendation was to not reimburse the particular therapy. And the reason was, and I've just popped in a very brief, quick excerpt from the recommendation. The rationale was that there was too much uncertainty around clinical benefit as well as cost effectiveness. So there was too much uncertainty for decision makers to be able to determine whether this treatment was going to, benefit the population in comparison to current standard of care therapies. With regard to this same therapy, in the UK through the National Health Services, the National Institute for Health and Care Excellence, NICE. So they recommendations that are binding. And what the recommendation for this same treatment was to allow reimbursement allow access through the Cancer Drug Fund alongside the development of evidence. And so what both of these recommendations are really acknowledging is that there is a tremendous amount of evidentiary uncertainty around therapies like this, but the recommendations were slightly different in terms of not reimbursing versus reimbursing alongside the required collection of evidence. So this is, again, just a really quick example to show how evidentiary uncertainty filters down into challenges and poses challenges for decision makers in determining, what in terms of allocating finite resources, does this therapy, does this technology provide value for money and patient benefit? So with that fairly extensive background, I now want to turn to the data set itself. So based on the background that I've just talked about, we acknowledged evidentiary uncertainty and kind of the implications that this can happen, that this can incur cross-jurisdictionally? This is our research question. So what data elements are required to support economic evaluations of precision oncology innovations? So now I'm going to talk for a few minutes about kind of the methods that we use to generate this data set, and then I'll move forward and talk in more detail about how we've moved this forward in terms of actually being able to implement it. Because it's one thing to say that these are the data elements that should be collected, and this is why, but it's quite another to actually be able to implement them in a feasible way within health systems. So just to summarize briefly, so this is a project that we've been working on for a number of years now, and it begun with a literature review. And so what we did is we decided we wanted to look at economic evaluations of precision medicine. And so we didn't just limit the review to precision oncology, but we also wanted to look at economic evaluations of rare diseases. And that's really because these two clinical contexts have been most common in terms of the implementation of precision medicine. So we conducted a literature review, and this was a scoping review. It wasn't a systematic review. We wanted to identify evaluations that had been most highly cited in terms of being influential. And we wanted to look at, the review was conducted for two reasons. The first reason was to develop kind of an initial draft data set. So what are the inputs? What are the costs? What are the outcomes that are measured across evaluations that are currently being conducted in this space? And we also wanted to look at these evaluations to identify areas of heterogeneity to be able to inform kind of next steps, and how can we use this work to fill certain evidence gaps or address challenges that we're seeing being faced in these economic evaluations. So we conducted this literature review. We data abstracted from 20 economic evaluations. We drafted our initial data set. And don't ask me how many elements were included in this data set, because it was very, very extensive. So it's been quite a process of taking this very, very long list and categorizing it and getting feedback on it. So we drafted the initial list, and then we engaged experts kind of in an informal manner within the research team and within and across BC Cancer, nationally, internationally. We hosted workshops where we circulated the draft data set, really in an effort to say, what's missing here? Are there any of these elements that are required that are not currently captured? Are there costs that we're not capturing? Is there any way to improve this data set? So we conducted sort of informal stakeholder consultation. Another aspect of this work, in an effort to kind of initially refine the data set, we were fortunate to be able to access existing clinical data sets. So for example, through BC Cancer's Personalized Oncogenomics Program, Marathon of Hope Cancer Centers Network. So we wanted to say, what are clinical investigations capturing? And are we ensuring that we're capturing similar elements? Is there anything missing here? So that process yielded an initial data set of 83 elements. And I'll also just call out one of our team members, Brandon Chan, really led that external data set mapping through very patient and meticulous mapping across all of these data elements, which was not a small task. So it was really appreciative to have him kind of lead that aspect of the work. So we ended up with 83 data elements from that initial phase. But I just want to quickly go back to the results of the literature review, just to talk a little bit about how that informs subsequent aspects of this work. So as I mentioned, we identified a draft data set, and we also identified substantial heterogeneity across these individual evaluations. And what this told us is that, having an absence of data or a lack of data does have implications for how economic evaluations can be conducted. So we found heterogeneity in terms of the data sources that are used to inform models. And so by data sources, I mean, were they able to access clinical trial data or other sources of primary data, administrative data? Did, for example, a decision model rely heavily heavily on expert consultation or published literature values. We also found heterogeneity in terms of what costs were incorporated into the evaluation. And I'll come back to this a little bit later because this was a major component of our work. Because this data set, we wanted to really focus on being able to capture costs as well as clinical and genomic elements and other elements that I'll talk about. And we also identified heterogeneity in terms of measured endpoints, and this was also a function of the available data. So in the absence of being able to identify death date, survival, many evaluations are limited in terms of, ending at something like diagnostic yield. And so we identified quite a bit of heterogeneity and a lot of kind of room for improvement in terms of, okay, what could the addition of additional data do to support future evaluations? And so what are some of the implications? I gave that example of the CADITH and the NICE decision making a few minutes ago, but some of the implications of an absence of data or a lack of data really bear on kind of an inconsistency in the evidence base. If similar economic evaluations are using different forms of data, they're applying different assumptions, simplifying assumptions. For example, what is the proportion of patients who receive an actionable result, and following that, what is the proportion of patients who actually initiate treatment? These are all assumptions that need to be applied in the absence of data. So we really wanted to work towards a data set that would mitigate the need to make those kinds of assumptions and to ensure that projections or estimations reflect the real world impacts of sequencing technologies. So following the literature review, the expert consultation, as well as Brandon's meticulous data set mapping, we identified an initial draft data set of 83 elements. And then we sought ethics approval to really move this forward to obtain formal stakeholder feedback for a data set that could support economic evaluation. So the surveys, we conducted a 3-part modified Delphi process. The first phase of this was a REDCap survey, an online survey. And I'll say that I'll go back a step or two here to say that we recruited individuals with experience working with precision medicine, whether it be within clinical, the clinical realm, decision-making realm. We recruited health economists, clinicians. We left our selection criteria relatively broad in that we really wanted to seek a diversity of perspectives and also in terms of geography as well. We didn't want to limit this to kind of a Canadian data set. We wanted to obtain international perspectives as well. So we used a snowball sampling approach. We recruited 46 individuals from a number of different countries, and we sent them a REDCap survey with 83 elements, and we asked individuals to indicate whether they thought that specific element was required or not required to support economic evaluation of precision oncology. We also obtained some qualitative feedback from our participants as well. A lot of that feedback was around feasibility of collection, and I'll get to that a little bit later. We then revised the survey in terms of the extent to which elements we had reached agreement on required elements, and then elements that had not reached agreement, we included in a round 2 survey, and we included a little bit of additional detail for some of those elements as well in terms of how they would be used or what they would be for, just to provide clarification. And then our round 3 of the modified Delphi was, it was an online conference, Zoom, and we brought individuals, we invited everybody who'd participated in previous rounds to join the call to really go through those final elements for which agreement had not yet been determined. We provided feedback on subsequent rounds, and we invited open discussion about a number of different elements. And that was really helpful to us in terms of refining the data set. And based on that work, we developed our final data set that's reported in the Value in Health paper. So I'm going to go through, I'm not going to talk about every single element. I would be happy to answer questions at any point about these elements, but they are all published in the paper, both the final data set as well as the initial draft data set, and we've got indicators in there in terms of where we reached agreement and where we didn't. But just very briefly, we categorize the data elements according to these 6 domains. And I'm going to go through each of these domains just really briefly, just to kind of pull out a few elements for discussion. So our first domain was patient characteristics, so capturing patient demographics at baseline. And so, things like age, sex, location, unique identifier. So this seems like a pretty obvious element, but not only is it, useful for de-identifying data, but also for linking across data sets. So when we think about, okay, what is the goal here? It's really to collect the most data that we possibly can. That often requires linking across different data sets. So we're very, very fortunate here at BC Cancer to have excellent and well-collected internal data holdings. So we have data from our tumor registry. We have BC Cancer Pharmacy data, we have scheduling data. We're really lucky in that sense, but the key there is to be able to link across data sets to bring in new data, as well as to validate existing data elements as well. So that was a really, really key one. Clinical characteristics, again, collected not only at baseline, but another component of this data set is not only looking at the data elements themselves, but thinking through when we can collect them, not only when we want to, but when it's feasible to be able to collect them. And that really enables us to be able to map these longitudinal patient care trajectories that I was talking about earlier, where it's really, really difficult. Sometimes things are not captured at all, or maybe something like performance status is captured at baseline, but we don't really know what's happening to individuals as they initiate new treatments or, alongside their quality of life. So we really want to be able to map what is happening to patients throughout the entire trajectory, not just of enrollment. Metastasis date. So this is another one that our group has put a lot of thought and effort into in terms of how do we capture this, this variable, because it can be extremely helpful to us when thinking through index dates, when thinking through, how do we identify a comparator cohort as well, covariate adjustment. A lot of these variables can be really, really helpful when we're trying to identify comparator cohorts that, for example, in the case where let's say we've got a single arm trial, and we have individuals with a particular aberration who received treatment. Well, if we have access to an external data set that allows us to identify similar patients with, for example, a similar aberration, but receive standard of care cohort, the extent to which we can obtain or identify similar characteristics so that we can match those patients is really, really helpful to us. So genomic elements, of course, this is a really important set of data elements, and I've really only included a couple here, but just thinking through, when was the biopsy taken, when did the sequencing occur, the genomics report, and even just those 2 types of variables, we can begin to map out or characterize features of the genetic testing process that are not only important to evaluators, but also can be important within the specific clinical context. So if we're able to identify when sequencing happened and when the report was returned, so not only the report itself, but also the date at which it was returned, we can begin to characterize turnaround time. And within particular patient populations, this can become very, very important if we're thinking about, what is the impact of genomic sequencing for a patient population with a poor prognosis or with, rapidly deteriorating disease. If it's a 4-month turnaround time, that can be really meaningful in terms of being able to project uptake or the usefulness or clinical actionability of testing. So being able to map out those dates is really important as well. And then, of course, the cost of sequencing and bioinformatics, which I will come to a little bit later when thinking through, okay, what are the relevant costs that need to be incorporated as well? So cancer treatment. So this is another set of variables where these variables are not only collected at baseline, but also it can be really important for us to be able to collect historical data. So what happened to patients before they were enrolled in this study or before they underwent sequencing? How much treatment, what kinds of treatment, what the extent to which they encourage, resources in advance of sequencing as well, because we know that those kinds of characteristics or factors bear on downstream health resource utilization. Creating indicators, or I've said flags here, for whether treatment was initiated, what treatments were initiated, and whether they were genomics informed. So again, this goes back to being able to mitigate the use or reduce the use of assumptions in the absence of real world data. So what is the likelihood that an individual receiving an actionable result is going to have their treatment changed by that result? And so being able to collect these types of variables can again help us generate more accurate assumptions. And then of course, result or patient outcomes here. So of course, collecting something like death date will enable us to more accurately characterize survival. And another variable that we've spent a lot of time thinking through is quality of life. So obtaining quality of life through validated measures, for example, the EQ5D can allow us to calculate quality of adjusted life years. And then also, and I'll get to this when I talk a little bit about how we've gone about implementing the data set, but being able to capture quality of life, not only at baseline or not only once or twice, but on a routine basis, so that we can more accurately characterize the patient experiences as it responds to, or as it reflects changes in their care, changes in treatment. So I'll come back to this one as well. And I just want to pause also to talk a little bit about cascade testing. So cascade testing was initially kind of its own domain within the data set. And cascade testing occurs if a patient is, if a germline finding is detected that has the potential to impact genetic family members. So being able to characterize the extent to which those family members then undergo testing, undergo potentially, primary or secondary prevention strategies. Those are the kind of spillover or downstream effects that may not pertain to every single evaluation. Those might be more research question specific, but still this allows us to capture those downstream kind of spillover effects that I alluded to earlier. And then, of course, as I have reiterated throughout this talk, our goal here was really to be able to capture relevant costs throughout. And so these are some examples of additional costs or resource utilization that could be attached to costs as well. So dates, number, frequency of hospitalizations, physician visits, we capture imaging, lab tests, as well as prescription medication. So I'm not going to go into any more detail about the specific elements. I really want to kind of push forward and talk a little bit about, kind of part of this was not only identifying what are the elements, but what's feasible to capture, how do we go about capturing, and how do we ensure that we're accounting for this entire patient care resource utilization trajectory. And so this is a version of this workflow that was also included in the publication, but really goes through kind of categorize, what elements we want historically, what we want at baseline, and then what we want moving forward. And this also includes, if you look at the sequencing and results rectangle under process, so we begin to really think through at what point following sequencing is there additional health resource utilization that can be accounted for, the costs of bioinformatics, the costs of any validation testing or confirmatory testing in the case, and this isn't always, a part of the sequence, but genetic counseling appointments as well. So really we wanted to kind of be able to obtain this really clear picture of, are we accounting for exactly everything that's happening throughout this workflow. And I also kind of want to step back for a second. You know, I've talked a lot about these different data elements, and then I've also kind of contextualized this within our work at BC Cancer. And I want to say that a lot of these data elements are captured and can be captured administratively. So we're not suggesting the collection of, 68 unique data elements prospectively, requiring a lot of additional allocation of resources to the collection of this data. A lot of these elements can be collected and are available to, certainly to us and to other institutions through administration or through administrative data sets. And, the kind of core aspect of collection or being able to use this data is really being able to link these data sets in a way that is we can try to move forward to link data in an analysis ready kind of way. So it's not only about the data itself, it's about how do we get it into a database? How do we get it ready to be analyzed? And I'll talk a little bit about that later, but I did want to kind of go back for a second and just talk about how, and this is, we can use these kinds of tables and the data set itself to think through, okay, what is currently being collected and what might we prioritize moving forward in terms of prospective data collection. And that's really where we've turned our efforts to, especially in terms of things like quality of life, the prospective routine collection of quality of life. Okay, so I just want to stop there for a second and, move a little bit forward in terms of kind of what have we been doing since we established this data set. And so I want to talk very, very briefly about an initiative that we have recently launched and how we're fitting this core data set into that work. So this project is called, we call it PREDICT, Precision Oncology Evidence Development in Cancer Treatment. This is a newly launched project, and really it combines existing data sources, the collection of prospective data, data curation, and thinking through building out data infrastructure for the specific purpose of being able to inform clinical evaluations as well as economic evaluations. So I'm just going to introduce the project very, very briefly, and then kind of talk about how we've moved forward. So again, this is just a quick snapshot of the PREDICT project. So the overarching goal of this project is to develop and pilot an early lifecycle HTA framework for precision medicine. And we're beginning this initiative with looking at these three specific protocols, really looking to build data and evidence for pre-reimbursed therapies at BC Cancer. So I'm going to talk briefly just about these kind of 4 separate protocols and how they're being brought together through PREDICT and where we're at, because it really, the economic evaluation you see at the center of PREDICT, which is really what it was built around, highly depends on having the data elements that we have generated here. So if you look over to the left of the screen, you'll see molecular. So this is the molecular protocol. And so we are looking to expand testing to identify NTRK fusions at BC Cancer as part of standard of care. So identifying individuals with this particular fusion, collecting data from those genomic reports. We've also got the clinical protocol, which is to assess the clinical effectiveness. So this is a single arm investigation looking at the application of a targeted treatment for individuals with NTRK fusions. So that provides us with clinical data. And then we've also got a quality of life protocol. And this is a really interesting aspect of the program because it builds on an existing program at BC Cancer called EPIC, which is implementing the routine collection of quality of life data across BC Cancer for patients with advanced cancers. And so our quality of life protocol here has really been focusing on expanding this EPIC program. And so it includes, we really had to think through how do we collect routine quality of life data in a way that is feasible. And I'll come back to that a little bit later, but that includes, making data collection convenient for patients, thinking through how frequently we can collect this kind of data, and also how we can use the data. And then all of these individual protocols filter down into the economic protocol, where we'll conduct the economic evaluation using the data elements collected across these different protocols. And so where we're at right now with PREDICT, as I said, this is a newly launched program. So we really wanted to start by identifying these core data elements. And now where we're at is really, it's very much a collaborative approach, not only with our own within our own research team, but also with a number of other external stakeholders to really think through how do we implement this data set in a feasible way, in a routine way, in a way that is sustainable over not only over the course of the study itself, but long into the future. So implementing the core data set really begins with collaboration. And I can't reiterate that enough, because we've been so fortunate through this program, and not only through the core data set itself, but even through the implementation efforts with the development of and the launch of PREDICT. It's really been an approach that has required stakeholder involvement across so many different aspects of BC Cancer and beyond. So communicating with our cancer genetics lab, thinking through what is included in a genomics report, how can we pull that information? Of course, clinical expertise. So our clinical colleagues, we've had many meetings about, okay, how do we typically collect this variable? Is there a way to improve collection? Is there a way to make it more efficient, to reduce clinician burden? What is infeasible at this stage? We've also collaborated with our experts in data science and really thinking through, okay, how do we make sure the data that we're getting is analysis ready? These are really detailed discussions about things like, they seem kind of very granular and really simple, but they're really important. So thinking through, is a missing data field or is a blank data field, is it simply, was it not entered, or is it genuinely missing because that patient never experienced that intervention or never had the data captured at that time point? So making sure what we're seeing in our data is accurate and complete, as accurate and complete as possible. I don't know if that was somebody trying to speak, but I'll continue on here. If anybody's analyzed a lot of data before, you understand the frustrations with open text fields. So thinking through, how do we create these, drop-down menus that are going to capture everything that we need? So to really, increase the likelihood that data is going to be captured accurately and completely. Of course, we've talked to privacy. We've communicated frequently with our privacy commissioner, talking with data and analytics here, making sure that we have the infrastructure to support linkage and what identifiers we should use. And all these types of individuals have been so helpful in being able to move this work forward. So just really briefly here, just in terms of lessons learned, and I think this has been such an exciting component of the work from my perspective, not only setting up, saying this is the data that we need, this is going to help us answer these really important and timely research questions, but how do we get it implemented across our health system? And my hope is that we can generate some discussion around other people's experiences with these types of questions. So again, sitting down with our clinical colleagues, thinking through, what is the sequencing workflow? What is the patient follow-up workflow? What is a feasible approach to data collection? So we talk, within our particular program, our focus is on individuals with a current metastatic diagnosis. And so these individuals are frequently at appointments, they're frequently filling out surveys, they're frequently filling out paperwork. So how do we integrate something like quality of life in a way that is not going to increase burden, that is going to allow us to capture the data that we're hoping to be able to capture? So within our EPIC, our quality of life program, we've really thought through increasing convenience of data collection too. So we have a platform that allows for the collection of quality of life data from patients at their own home. So they don't need to come to clinic 15 minutes or half an hour before their appointment. They can do it in advance. And we've also integrated real-time follow-up from clinicians based on their responses. So it's not just collecting data for the purposes of collecting data for research, but we want to have patient impact there as well. And then really discussing, when we think about the genomics report itself, what are the key elements that we want to include. So that's a big data domain in terms of what is generated and what we specifically want to collect. So thinking through how are tier 1, tier 2 findings collected, how do we flag for whether a treatment was given that was based off a genomic finding. So those kinds of questions, they require collaboration and they require meetings and thinking through feasibility. And that's kind of been the exciting component that we've been working on over the last little while. So just to summarize, just thinking through some of our kind of key learnings and what we hoped to get out of this work. So I've just popped up here, we present a minimum data set, and I've bolded and underlined the word minimum because I think this is kind of a key outcome of this work is that this data set was not intended as to be completely exhaustive and to say these are the only data elements that should be collected. This is really intended to be that's why we call it a minimum data set or a core data set. And so our hope is that future investigators seeking to begin to collect data through clinical, real world observational data studies or economic evaluations can look at this data set and build on it depending on their specific research question. There are things that are not included in this minimum data set. And you can also see that if you look at the larger data set, the pre-Delphi version of the data set, like not everything got captured. And so this is really intended as not only kind of a baseline, but also kind of a framework to begin to think through how to build out data collection, data infrastructure within external institutions across different jurisdictions. So what is readily available? So thinking through what is currently collected and maybe where to prioritize prospective data collection, because some data collection does require, in some instances, would require, obtaining ethics approvals. So, for example, collecting quality of life perhaps is not included standard of care. Perhaps it's included as part of, an initiative alongside an investigation. So thinking through those kinds of things has been really helpful, certainly for us moving forward. So, the intention of this work has really been to begin to think through standardizing data collection, not only within our own institution, but also being able to enhance the comparability of economic evaluation. So if we're conducting an evaluation within BC, being able to generate something that can be compared elsewhere in a different province or in a different country. So we can, again, really build out that evidence base. We want to enable the use of real world evidence. I think from my perspective, it's really well acknowledged that there's a role for real world data and real world evidence in evaluating these innovations in a timely way. We can't always wait years and years and years. This is the space that we work in is rapidly moving forward. And I think that data collection and evidence generation should be responsive to that. So our hope that this data set can kind of move that forward as well. And then, as I said a couple minutes ago, my hope here, and certainly for this discussion as well, is really just to begin to have discussions around how can we take some of those first steps? How can we begin to standardize data collection, which may ideally result in standardizing the economic evaluations themselves and thinking through these assumptions and how do we mitigate the shortcomings of our current assumptions and reduce or mitigate some of the limitations of current economic evaluations. So I think I will stop there for now. I just want to acknowledge, my lab and the larger CLIO network and a lot of the people who've been involved in this work from the beginning. And of course, I want to thank our collaborators, our research participants who were really helpful to us throughout this Delphi. Another kind of side aspect of this work that I always come back to is that, we conducted this all during the COVID-19 pandemic, and it speaks a lot to the level of engagement that we were able to receive from people throughout the Delphi process, through sending them surveys and receiving feedback. And we couldn't have done this to this degree without their engagement. So really appreciative of that aspect of this development process as well. So I will stop there, but thanks very much for listening, and I'd be happy to have a discussion. I think we have a few minutes remaining.
Awesome, thanks so much, Samantha. That was fantastic. So we've had a few questions come up in the chat. A couple people have put in a couple questions, so I might kind of choose one of those at random, and possibly, if we have time, come back to the remainder. And anyone else who has questions, feel free to pop them in there. So one of the questions that we've had from Scott Gross is that in the US, one of the most important demographic characteristics for assessing health equity in outcomes and access to treatments is race and ethnicity. And so that might be context dependent, but he's asking, does our framework address the collection of demographic information specifically for assessing health equity?
Thanks very much. That's a really great question. And I think that really speaks to the fact that, again, this was a minimum data set, and we absolutely recognize that there are demographic variables in here that are not collected. Race, ethnicity is one of them. Another that also came out from our reviewers when we submitted the paper for publication was gender as well. And I think that those are incredibly important to account for. I also agree with Didi that they can be kind of context or research question specific. The other thing that comes to mind is the integration of kind of patient values and preferences within individual research investigations, and kind of the role for speaking with patients, conducting, whether it's qualitative research or having patients as part of the research team to help to inform those additional variables as well. What is important to people are issues related to health equity, to access to care, access to treatment. Are those coming up, and how can those be integrated into the individual investigation? So I think that's a really, really great question, and absolutely something that needs to be accounted for sure.
Awesome. Thanks so much. Another question here from Sam Hong. So I'm going to go with the question that's more related to the second part of your talk. So related to the PREDICT project, Sam is asking, can you speak to any key differences in data elements that are required for assessing the value of a targeted treatment, like entrectinib for NTRK fusion, versus evaluating the diagnostic, so Foundation 1 liquid CDX?
Yeah, I mean, so for entrectinib in particular, what we're particularly interested in is a lot of kind of what I talked about earlier. So, so within a diagnostic, we're thinking about what is the probability of, or what is the likelihood that the aberration is going to be detected, because that's of course going to have substantial bearing on something like diagnostic yield. But when we think about something like entrectinib, we're not only interested in what is the likelihood of detecting an NTRK fusion, and we can get that through our molecular protocol, but what happens after that. So for entrectinib, and speaking to the the CADTH PCODER recommendations, they did have information on these really short-term kind of endpoints, but it's what happens after that. So once somebody's identified as having an NTRK fusion, what are the treatments that are available to them? Are they accessible? Are they reimbursed? Can the patient afford them? Are they willing to pay for them? Are they, is that report returned within a meaningful time frame such that a decision can be made about changing treatment. And then of course, far beyond diagnostic yield, and that is certainly something that we see, especially in the rare diseases space. Diagnostic yield is often kind of the primary outcome, but for something like entrectinib, we want to know, okay, what happens after that? What happens in terms of whether treatment changes, what happens when they're on treatment, what other healthcare resource utilization are they incurring, how often are they hospitalized, what is the time to next treatment, what is their survival, what is their quality of life. So it's really, it's just for something like entrectinib and treatment change, it's more longitudinal. We need that data to capture what happens downstream.
I think that's a great point, and it feeds nicely into another question that Sam Hong had asked that was more related to the core data set, but around whether safety and adverse events from treatment would be collected alongside patient outcomes or alongside resource utilization, and how you might distinguish between what is due to adverse events and what is routine in terms of resource utilization.
Yeah, so thanks for that. That's a really great question. And adverse events is something that was included in, I believe you will see it in the very extensive 83 item list. So it is certainly something that we captured. And again, I think it's something that, depending on the research question itself, could be included. But of course, we have other variables within the data set that could speak to adverse events. So we have, hospitalizations, cancer and non-cancer prescriptions that are captured following sequencing. And then of course, as well, we have quality of life data, which could further speak to, if we're beginning to see, if we see treatment initiation and we see a decrease in quality of life, and we could kind of, I think the key is also being able to amalgamate or kind of triangulate different elements to be able to get at something like adverse events if we're seeing this drop in quality of life, or if we're seeing an increase in healthcare utilizations or prescription medications, those kind of things. But again, as I said before, like adverse events is something that was discussed heavily throughout this. And I think, again, it's something that could easily be or importantly be captured as well. But certainly something really important when we're speaking to, the patient experience and how they are impacted beyond something like survival is really, really important, and something I think is missing.
Awesome. So there's one more question in here from Scott Gross, and then maybe I'll ask a question to you as well. But one more question, sort of a comment as well, just asking about your definition of precision medicine, given that there's a lot of variety in terms of how people use the term. Sometimes it's used to refer to individualized treatment, whereas other times it's referred to as, stratified recommendations based on membership in what is actually a fairly large group. So just curious if you could comment on that.
Sure. Yeah, absolutely. I think it's a really good question. I think I also think it speaks to a lot of jargon that is used in this space, and I think it really is important to define things. So thanks for that, and I'm happy to kind of follow up with you, or if you have anything to add to that, Dr. Gross. But yeah, so for the purposes of this, really what we're talking about is being able to use, genetic testing, genomic sequencing, whether it's a whole genome or an exome, or multi-gene panels, which are really common here at BC Cancer, kind of these parsimonious panels that specifically include the detection of findings that are theoretically actionable. And so that's really what we were focusing on for the purposes of this project, and being able to identify, targetable aberrations. I'm not entirely sure if I answered your question, but happy to chat more with you about that.
Well, actually, I'd like Scott to write a commentary on this. I get asked this question every time I present, Scott. And I come up with my own definitions. I was like, I don't know. If we could have a definitive commentary, I'll help you write it if you want, about the definitions and when they are appropriate or not. I gave a talk at Harvard, I guess a month or two ago, and they just really took me to task on my definition of precision medicine. So Scott, please write that.
Fantastic. So maybe one last question here. So I'm curious, in your experience implementing the core data set or seeking to, what have you found most challenging in that process?
Thanks. Yeah, I think that's a really good question, and certainly something that's very top of mind to us. And I think I've tried to speak to a couple of aspects of that. I think the first is the prospective data collection bit. I think, again, as I said, we're really, really fortunate to have these wonderful internal data holdings, but thinking through how do we collect data prospectively from patients, but also from clinicians. Clinicians, asking them to, include another flag or another indicator, is not an easy task, and they're very busy. And so to be able to think through what's feasible in terms of additional data, thinking through progression, as has been a challenge. How do we collect progression on an ongoing basis? As I said before, date of metastatic disease. So this is another one that to date requires manual data extraction. So how can we think through a more systematized approach to identifying date of metastatic disease? And then, of course, as I said before, kind of the quality of life bit, balancing burden for everyone, because we want to make this sustainable. We want to make this feasible. We've been really fortunate through Predict in that we've been able to collaborate with our clinicians to develop a REDCap database to collect a number of these prospective data elements. But again, that's been a series of conversations around, okay, how frequently can we ask for this to be collected, or can we get it through another source? Is it going to be in the clinician notes? How can we pick that up? So I think those conversations have been the most challenging, but also the most exciting, because it lends itself to a more meaningful application of this work.
Wonderful. All right. Well, thank you so much. We are at time and really appreciate everyone for attending today. Please feel free to follow up with Dr. Pollard over email if you have any additional questions.
Thanks, everyone.